Welcome back. Chapter 7 is titled Health Literacy, and it asks a question that sits beneath everything we've discussed so far in this course. Even when health information, care, and resources exist, can people actually access, understand, and use them? This chapter matters enormously across all three of the fields that some of you come from. Communication students will recognize health literacy as a communication competency issue as much as an individual skills issue. Literacy, if you recall, is co-produced between a speaker and an audience. It's not just a trait that one person has within themselves. Health sciences and nursing students will see health literacy as a direct, daily clinical variable. It shapes medication adherence, comprehension of discharge instructions, and patient outcomes. Whether your minor is in psychology or disability studies, health literacy helps you relate with the populations you deal with and relate to in meaningful ways. By the end of today, you should be able to define health literacy and its many subtypes, apply it across personal, clinical, digital, organizational, cultural, and community contexts, and start thinking about how you would advocate for health literate communication in your own future practice and careers. Let's preview today's 6 objectives. The first one is to understand the evolution and meaning of health literacy as a concept. This isn't just a static one definition term, it has grown considerably over time. Second, we'd like to identify the different types of health literacy and explain their significance from a WPHC and SJA perspective. This is what's really important in how people construct their health outcomes. Third, apply health literacy in personal, social, community, and organizational contexts. Fourth, engage different audiences in applying health literacy from a WPHC and SJA perspective. Fifth, understand how the cultural construction of health shapes health communication. Last, advocate for and enact communications behaviors that exemplify health literacy principles from a WPHC and SJA perspective. If you look closely, you'll see the verbs building across these 6 objectives: understand, identify, apply, engage, understand, advocate. So this chapter is designed to move you from definitional knowledge toward action. Let's start where health literacy actually shows up for most people, not in a hospital, but in everyday life. At its most basic, health literacy is the knowledge and ability to understand health information. Today, we'll cover the importance of health literacy, the challenges facing it, the consequences of low health literacy, what an inclusive application of health literacy looks like, and the significance of WPHC and SJA contexts in health literacy specifically. Let's see how we can relate to it in concrete ways right away. Take a few moments to browse the teen magazine and look specifically for health-related content. You'll see the links under the module lecture slides provided by the slide number here. So you'll see the link for the teen magazine under slide 4. Once you browse through the teen magazine, try and see how many items of health information can you identify on this site. How did you use health literacy skills to interact with that information? What does that include? Reading, evaluating its credibility, comparing it with what you already knew. Take a moment to do that. Before we can fully define health literacy, we need to define literacy itself, because health literacy is built directly on top of several more general literacy skills. Kirsch defines literacy as a combination of reading, writing, basic mathematics, speech, and comprehension skills. Notice this is already broader than can this person read? It's a bundle of related competencies that intersect with each other. Let's look at these in more detail. Oral literacy. This comprises the components of speech comprehension, listening and interpreting gestures, expressions, and tone within the context in which they are used, in order to make sense of the overall logic and organization of what a speaker is communicating. Print literacy. The ability to read, write, and understand written language that is familiar and for which the person has the required background knowledge. Fluency. The accuracy, rate, and appropriate phrasing and intonation of words. Readability. This depends on the skills and background knowledge of individual readers, factors within the text itself, and the purpose for which the readers are using the material. Already you can see why a single patient handout written at a single reading level, let's say for an 8th grade or a high school level readability, will land completely differently depending on a patient's oral literacy, print literacy, fluency, and the purpose they brought to reading it in the first place. Two more foundational literacy types round out this list. Numeracy, when patients use basic calculations such as addition, subtraction, multiplication, and division to do things like read medical labels or try to understand the times and days for medication administration. They're drawing on the numeracy dimension of health literacy. This is also known as quantitative literacy. Functional literacy. This is the use of literacy to perform a particular task. Seen together, this gives a comprehensive view of health literacy, which are these different forms of literacy, oral, print, numeracy, and functional, come together under the single umbrella term, health literacy. Interpreting and acting on health information effectively often requires complex print, numeracy, and functional literacy skills operating simultaneously, not just one in isolation. Let's apply numeracy and functional literacy directly with a real-world concept review. With someone you know, let's say your roommate or someone else, a friend, discuss the different sports drinks reviewed in this blog. Very well fit, best sports drinks. You can see the link under the lecture for slide 8. Then review the Harvard T.H. Chan School of Public Health Nutrition Source Sports Drinks page. That would also be on the same slide 8 link provided under the lecture slides. Now, based specifically on grams of sugar, which drinks reviewed in the Very Well Fit blog would be better suited for heavy sweaters versus which might be marked around immune system support? That requires health literacy. So based on the grams of sugar, you're going to have to calculate this requirement. Which drink would you recommend for heavy sweaters and which for someone seeking an immune system boost claim? Which numeracy skills do you think you will use to answer that question? And which functional literacy skill did you use in comparing these two sources? Try this out with a friend. And do a spot check on your functional and numeracy literacy skills. Now that we've defined general literacy, let's build on the full definition of health literacy specifically. Health literacy is the application of literacy in combination with other skills and abilities of the individual, specifically within a health context. It includes the healthcare skills required for maintaining one's health, preventing disease, or obtaining treatment and getting well when sick. As you can see, this is more than the ability to read. An individual with low health literacy may be perfectly able to read the words in front of them, but may still not be able to comprehend the actual meaning of the information, evaluate it in the context of their own life and circumstances, or consider how it compares with similar information from other sources. This has a direct implication for anyone designing health communication. For individuals living with low health illiteracy, simply providing access to information is not enough. Crafting the conditions for their empowerment must be done in a way that actively ensures health equity. The responsibility doesn't end at, "Oh, we published the pamphlet." So our patients or our clients will obviously understand what was written, and very clearly they'll be able to apply it in their lives. Let's use this moment to pause and make sure that comprehensive definition has really landed. Health literacy sits at the intersection of individuals' own skills, the complexity of the information or system in front of them, and as we'll see in some detail today, it is the responsibility of the organizations and communicators producing that information, which is really important. Let's ground this in the clinical setting specifically. Patient health literacy allows people to communicate effectively with healthcare providers, negotiate the complexity of healthcare settings, and obtain proper and timely care. The disparities here are well documented and sobering. Patients who are members of racial and ethnic minorities, who have limited English proficiency, and who have low health and digital literacy demonstrate measurably poorer patient-clinician communication scores. Some of you may even relate this information to disability advocacy or deaf communities and other such minority communities. So this is a critical moment for both communication students and nursing and health sciences students to sort of dwell on. This isn't a claim that these patients are somehow deficient. It's a finding about how poorly our current clinical communication systems are designed to reach the full range of patients they're meant to serve, and especially those that really do need that service. Now we should transition a little bit into personal health literacy, and the kind of subtypes that we'll walk through with the next several slides will include the full range from medication literacy, disease literacy, digital health literacy, to e-health literacy. Medication literacy. Medication literacy references the specific skills required to take medications correctly. This includes understanding the concepts of measurement, being able to read and correctly interpret prescription labels, keeping track of active ingredients across multiple medicines. This is especially important for patients on several prescriptions at once or comorbidities, and understanding complex directions from healthcare providers about how and when to take medicines. Certain populations face particular challenges in this mix. Older adults, people with limited vision ability, and people with limited English language skills, to name a few. Notice how each of these barriers is a mismatch between the design of medication information. For example, things like small print, English-only labels, complex multi-step directions, and a specific identifiable population's actual capacities. So how might we bridge this gap? Disease literacy refers to a lack of adequate, objective, unbiased knowledge about disease conditions. Minority cultures have their own unique challenges with disease literacy. For example, stigma around certain conditions that cannot be painted with a single generic brush. Different communities face different specific barriers. Importantly, disease literacy gaps can persist despite a person having English proficiency, like a college education, steady employment, and an existing well-funded connection to a health system. This tells us that disease literacy is not simply a substitute for general education or socioeconomic status. It has its own distinct drivers, including trust, stigma, and cultural framing of the disease itself. Think about this very specific example from research. Limited health literacy has been associated with decreased use of preventive health services by African immigrants, and with increased barriers to accessing and utilizing healthcare more broadly. The World Health Organization defines digital health literacy as the ability to seek, find, understand, and appraise health information from electronic sources, and to apply the knowledge gained to addressing or solving a health problem. This shows up across several distinct contexts: product websites, the websites of organizations providing healthcare information, and insurance websites, searching for providers, pharmacies, or insurance options, and researching medication side effects all require the ability to access the internet and navigate the online information environment. Digital health literacy, therefore, is especially important and not very equally distributed. In the specific domain of online health information seeking. As you know, this is one of the most common ways people first encounter health information at all. Let's take a little detour and apply digital health literacy directly with another concept review. Here's a federal health website for CDC. It's their youth health site and it's titled Healthy Youth. Now grab a hold of your roommate or a friend and take a look at the site. Under the handouts, you might also take a look at handout 7. Try and understand the inclusive communication guidelines using the WPHC and SJA action steps to see how well does this CDC's website meet those criteria for inclusive communication guidelines. How well does this website address the specific digital barriers that a population with low digital health literacy might face? And this is where my communication students can see the challenges in really where the rubber hits the road in translating that information or presenting and communicating it in a way that it makes sense in the context of the lives of those who need it. Core challenge here is straightforward enough to state, even though it has far-reaching consequences. People with low digital health literacy find it harder to use technology for health-related tasks. As more of the healthcare system, including appointment scheduling, checking on your test results, navigating insurance claims or applying for them, prescription refills, moves online, this single gap compounds across nearly every point of the contact with the healthcare system. Let's go one level deeper with a more formal definition. Page and colleagues define e-health literacy as the ability to locate, understand, exchange, and evaluate health information from the internet in the presence of dynamic contextual factors and to apply the knowledge gained for the purposes of maintaining or improving health. This is described as an intrapersonal skill set that enables consumers to negotiate online transactions among diverse sources in the face of adversity, such as dexterity limitations or the use of unfamiliar jargon. Page and colleagues further distinguish two levels of e-health literacy. First, functional e-health literacy, which is the ability to use the basic features of technology, such as typing and reading on a screen, to access and comprehend health-related content. And the second is translational e-health literacy, which is the highest level ability to create and carry out an action plan that applies knowledge obtained, negotiated, and evaluated online for the purpose of health promotion. So this form of e-health literacy specifically emphasizes accessing a person's ability to produce text messages, communicate with multiple online users, determine source credibility, and critically translate the knowledge gained from an online transaction into offline action. This last step, translating knowledge into lived behaviors, is where a great deal of health communication effort actually breaks down and is really important to attend to. Having built up all these forms of health literacy, we now turn to what happens when it's absent or actively undermined. Health information, misinformation, and digital health disparities. Let's focus first on health misinformation. Health misinformation is a serious threat to public health. It's defined by HHS.gov as information related to one's health that is false, inaccurate, or misleading, according to the best available evidence at the time. The consequences of health misinformation are significant. Health misinformation may cause confusion, create mistrust in expert sources and scientific knowledge, harm people's health directly, and undermine public health efforts more broadly. Think of how a single piece of viral misinformation can complicate an entire vaccination campaign or public health response. Notice the phrase, according to the best available evidence at the time, in the definition. This acknowledges that scientific understanding evolves, while still holding a clear workable standard for what counts as misinformation at any given moment. Digital health literacy gets applied across a range of contexts. These include accessing electronic health records, communicating electronically with healthcare teams, discerning reliable online health information, and using health and wellness apps. Digital health disparities stem from unequal internet access combined with low digital health literacy skills. Specifically, this means affected populations either don't have equal access to mobile technology, aren't familiar with using mobile health applications, or cannot comprehend the information in a manner that leads to actionable knowledge. These disparities can be addressed through deliberate strategies, presenting health information in a more comprehensible manner, and identifying approaches for integrating social media into health promotion interventions, specifically for health issues affecting medically underserved groups. Let's look outward a bit on a more broader scale, from the individual to the systems around them. Organizations, cultures, and community contexts of health literacy. Let's start with the organizational level, which includes things like healthcare systems, clinics, and public health agencies themselves. Organizational contexts of health literacy are, frankly, under-recognized. Health literacy is best understood as a balance between an individual's skills and abilities and their ability to navigate the complexity of the healthcare system and the organizational, social, and media environment around them. The responsibility is shared, not located solely in the individual. Organizations can help their members become more health literate and can ensure their own communications and initiatives actively improve health literacy for all members, not just the most literate ones. This is especially important in rural and underserved areas and for minority and marginalized populations. A recurring challenge is low awareness of health literacy generally and of the specific challenges low health literacy poses for minority patients within the organization in inter-staff communication and in patient communication. So what can organizations actually do? Palumbo and colleagues argue that healthcare organizations can support a patient's ability to navigate the online healthcare environment and support their ability to co-create, share, and access information, treating the patient as an active participant in the information environment, not a passive recipient of it. The National Network of Libraries and Medicine offers a concrete action list for organizations pursuing these goals. Here are 5 of them. Ensure everyone in the community can access the health information they need. Second, provide health information in plain language and in different languages. Third, provide training to health professionals on health literacy best practices. Fourth, create a database of health literacy information for health professionals to draw on. And fifth, Review health materials like insurance forms and medication instructions with community members directly to confirm they understand both the information and the actions that they need to take. So this last point is worth emphasizing. It moves organizational health literacy work from a one-way communication model, which is we published a plain language pamphlet, to a dialogic, verifiable, meaning-making, co-constituted model with the community itself. Next, let's move to the cultural context of health literacy. The National Library of Medicine defines culture as the shared ideas, meanings, and values acquired by individuals as members of a society. Our group belongings and memberships, whether they are racial, ethnic, or linguistic, for example, shape our identities and our culture. Culture, in turn, shapes our understanding, our thinking, and the ways we respond to human experiences and world events, including health experiences. This has a direct implication for health literacy. Individuals who are members of professional cultures such as medicine and public health communicate using a specific language or a specific set of language skills, sometimes also known as jargon to those who are not a member of that group, which often include complex epidemiological and medical terms. In other words, medicine itself is a culture with its own linguistic norms, and health literacy gaps often occur exactly at the boundary between that professional culture and a patient's own cultural and linguistic frame. Let's look at 3 specific cultural concepts that shape health literacy in practice. The first is acculturation. This is the ability to assimilate into a given culture. Acculturation comprises a range of factors, including English language proficiency, interactions with family and friends, and interactions with neighbors. Second is culturally sensitive communication. Practices that healthcare professionals can follow to facilitate communication that respects cultural context. For example, understanding the strengths and weaknesses of online cancer communication for affected at-risk groups and supplementing that information with oral and tailored communication rather than relying on written materials alone. Third, cultural linguistic identity. Minority cultures encompass a wide range of racial and ethnic identities, cultural values and beliefs, languages, and educational and socio-economic characteristics. Tailoring to the cultural linguistic identity of each minority culture and to how health literacy itself is understood within that specific culture is important for positive health outcomes. So just think about it. We're talking about tailoring to the cultural linguistic identity of each minority culture. So we are talking about culture and the linguistic identity and trying to apply health literacy within that specific culture. So bridging these will lead to positive health outcomes, but that's a complex health literacy skill. And that's important because it's so easy to start seeing minority culture as a unidimensional thing, which it's not, of course, and a single cultural adaptation strategy will not work equally well across every group it's applied to. Last, let's look at the community contexts of health literacy. So now we are looking at the broadest context in this chapter, which is the community. start with social capital. Social capital, the networks of relationships among people who live and work in a particular community, enabling that society to function effectively, plays an important role in shaping health literacy and health information seeking behaviors. There are a few important concepts in social capital. We look at two of them right now. The first is bridging social capital, which is the social capital between people who differ based on socioeconomic and other characteristics. This contributes to how health literacy impacts health information self-efficacy, which is connecting with people different from yourself, can open up access to new information and resources. So this is where we think about bridging social capital. So people who are different, for example, on socioeconomic and other characteristics. And these sort of connections can impact health information self-efficacy in positive ways by opening up access to new information and resources. The second type is called bonding social capital. This is the social capital between people who are similar to each other based on socioeconomic and other characteristics. So instead of bridging, this is bonding. What this does is kind of weakens the relationship between health literacy and health information seeking intention. So between health, sort of connecting across and connecting within, there's an important but subtle distinction. Bonding social capital, which is with people just like us, can sometimes reduce the perceived need to seek outside health information, if you think about it. While bridging social capital with people different from us can sometimes expand our ability to look for and access new information and resources. Within a WPHC and SJA context, cultural factors play a key role in determining which community members individuals will turn to for health information gathering and decision making. Cultural related factors play an important role in what individuals from particular communities believe about health and illness. Think about who you turn to, maybe family members and friends, and how they think about health and illness as being serious or non-serious, and when we turn to for treatment and when we don't. Cultural and community-based knowledge is an important factor in how an individual understands health and illness in the first place. And social support from community members, family members, caregivers, and friends provides an important cultural context for health information seeking. So this kind of reframes the concept of who a patient trusts for health information. That's not like a static, random preference. It's shaped systematically by culture, community knowledge, and existing relationships of support. So what can communities do? One concrete strategy here is empowerment education, helping train community members to engage in critical reflection on how health meanings are constructed in the first place. What does this involve? This involves helping community members understand how their own meanings of health reflect their socioeconomic and political environment, and to help them see how those meanings of health have implications for how they make decisions about their own health. In practice, this can often take the form of workshops and training focused on critical reflection, which involves things like helping people see whose opinions they've come to value, how they came to hold a particular form of knowledge about health over an alternative meaning-making scenario, and how their own understandings have shaped their individual health experiences. So why are community factors important, and why does all of this matter? Community-based health literacy skills build awareness of power relations and socio-economic factors. In order to bring about positive behavioral change, especially in underserved communities. In short, this work promotes knowledge that creates the actual conditions by which community members can bring about positive change themselves. It is very different from knowledge handed down from outside the community. It's the knowledge built with and used by the community that's so powerful. So lots of ground covered today. We've taken a look at literacy from a 365-degree angle and carefully and in depth examined the many types of literacy underlying health literacy, personal and clinical health literacy, medication and disease literacy, digital and e-health literacy, health misinformation, and organizational, cultural, and community contexts of health literacy. So before you move on to the reading review, quiz, and the engagement and advocacy application assignment lab, which has lots of handouts for you to apply these concepts in a range of contexts and to really sort of like work with them in an applied manner, here are a few prompts for you. Take a look at what might be 3 things that stand out for you from today's talk and lecture, and how will you engage them in your community? For example, can you think about the 4 foundational types of literacy that combine to form health literacy, like oral, print, numeracy, or functional? And can you explain why more than the ability to read is central to the definition of health literacy? What are the 3 things someone with low health literacy might struggle to do, even if they can read the words? Can you maybe distinguish functional e-health literacy from translational e-health literacy? Or define health misinformation and name 2 of its consequences? Can you think about how we distinguish bridging social capital from bonding social capital, and explain how each relates differently to health information seeking? These are just a few of the points, exciting and interesting points with very real implications for a range of minority and marginalized at-risk populations that we've discussed today. And these are some of the ways in which you could make a very important difference, whether you're from communication, nursing, or health sciences, in the lives of those patients.